Well, as you can see, my topic is reviewing disease-modifying therapies in Alzheimer's disease and the potential challenges of implementation. This is quite exciting time for us in the field for some good reasons. So hopefully I can share that with you all. These are my disclosures as you saw before as well. So this is the outline of my talk. I first will review the evidence for three anti-amyloid monoclonal antibodies, aducanumab, lecanemab, and donanemab, followed by description of current and near future of clinical trial designs in Alzheimer's disease, and finally, talk a little bit about the impacts of disease-modifying therapies in Alzheimer's disease in real-world requirements and challenges. I'm going to start with this case report. First, it's about a very young patient, 51-year-old Caucasian female with 8th grade education without any significant past medical history or family history. Her father died at a very young age, and her mother didn't have any significant medical history. She was married for 28 years with one daughter, and she worked as a seamstress assistant. She developed sudden onset of behavioral issues, mainly accusing her husband of adultery without any reason. So it was more of delusional thoughts, hallucinations, and also aggressive behavior. And then after that, she developed some cognitive issues to include mainly the speech difficulties, difficulty with writing, and also object recognition, and also lost sense of direction. Can I ask if people can mute their microphone? That would be great. I can actually hear something in the background. So she has a very rapid deterioration of cognition, and she became dependent on managing day-to-day function. And then in 5 years, she became bedbound and passed away at the age of 55, again, very young age, due to pneumonia and septicemia related to dementia. This is the first case of Alzheimer's disease when Dr. Aloy Alzheimer, at the turning point of 20th century, was taken care of. Patient's name was Augusta Deter, as you can see here. And of course, this is not HIPAA. In 20th century, there was really no HIPAA, so this is a public information. And Dr. Alzheimer was taking care of this patient for 5 years, from 1901 until 1906, when patient passed away. And when she passed away, he looked at her brain under the microscope, and he saw these two entities. He didn't know exactly what they are made up of, but he called this one here, as you can see, as plaques. And then he called this structure here as tangle. But he didn't know, again, what they are made up of. And we didn't know either until 1984, when two scientists, Drs. Glenner and Wang, they discovered the backbone of amyloid, backbone of those plaques, that was amyloid protein. And then 2 years later, Dr. Iqbal from New York University discovered that the backbone of tau is, the backbone of those neurofibrillary tangles are phosphorylated tau. Nowadays, we can image the amyloid plaques in a living human being. This is a study of one of our patients, one of our research studies. This is a patient with Alzheimer's. What you see here in hot metallic color in front of the brain, these are axial sequences. These are horizontal sequences. What you can see in front, shown by the arrow, these are all amyloid deposition in the brain, and this test is quite accurate. And also, we can now image tau with another imaging called tau imaging. These are head-on images, and you can see the tau deposition in the hippocampal area and entorhinal cortex, and also inferior and middle temporal lobes here. So, if you're going to talk about treatment, in any type of disease processes, there are two different therapeutic approaches. One is symptomatic treatment, and the other one is disease-modifying therapy. So here, what you can see in horizontal line, that's age or time. In vertical line, that's cognition and function, and the arrow shows the direction of decline. In solid blue, that's curve that you can see in solid blue, that's the natural course of Alzheimer's disease. If you don't really give any medication or if you don't really interfere, as you can see, people will decline cognitively and functionally and finally pass away at certain point here. Versus this red line, this is symptomatic treatment. And as you can see, when we start people on symptomatic treatment like donepezil or galantamine or rivastigmine or memantine, we can have a little bit of a boost in symptoms, but as you can see, the outcome is the same. So it doesn't really change the trajectory. Versus in green, if you start people on disease-modifying therapies, this is when we can change the trajectory, we can change the slope. And we are really looking for disease-modifying therapies in any type of disease processes, including Alzheimer's. And by the way, don't get me wrong, symptomatic treatment is very important, but the ultimate goal is to develop disease-modifying therapies so we can change the trajectory. Let's take a look at the landscape of Alzheimer's disease treatment within the last 3 decades. As you can see here, these are all the ones that I circled, all symptomatic treatments. Started in 1996. The first one that got the FDA approval was donepezil. And then later on, after 4 years, rivastigmine got the approval in 2001, galantamine. These are 3 cholinesterase inhibitors. And then finally in 2003, memantine, which is an NMDA antagonist, different class of symptomatic treatments, got the approval. We didn't have any movement in the field until 2023, when lecanemab got the full approval from the FDA. So as you can see, there was a 20-year gap between the last medicine that was symptomatic treatment that got the FDA approval until the first disease-modifying agent, which is quite remarkable. This is the current landscape of disease-modifying agents. We have 3 of them, and I'm going to discuss each separately. So aducanumab got the accelerated FDA approval on June 7, 2021. Lecanemab got the full approval on July 6, 2023, last year. And then donanemab, the sponsor, the Eli Lilly company, they presented all the results that I will share with you last year, and they are before the FDA to get the FDA approval, and we hope that they can get it very soon. Just to tell you a little bit about the mechanism of action of these anti-amyloid antibodies. These are, again, all anti-amyloid antibodies. These are infusion medications, and as you can see here, they are infused through the vein, and that's within 1 hour. The amount that they cross, these medications cross the blood-brain barrier is very low. It's 1 to 1.5%. But that's enough to go to the brain and bind to either amyloid proteins that are soluble or the plaques in the brain. And they will activate the immune system, the glial cells in the brain, and the glial cells will remove those amyloid plaques and proteins. And these are quite strong medication. And I will share that with you as well in just a few minutes. So let's first talk about aducanumab, the story of aducanumab. In 2012, Biogen started a clinical trial with aducanumab, and the name of the trial was PRIME. That was a phase 1b, phase 2 clinical trial, 52 weeks, 1 year. That was a randomized controlled trial, 166 participants. This trial was positive in terms of removing amyloid significantly and also showing slowing down of memory loss. What you see down there, that's a horizontal cut or axial cut of amyloid PET imaging of a patient before and after treatment, after 1 year of treatment of lecanemab, of aducanumab. What you see in hot metallic color, that's amyloid deposition in the brain. And as you can see, after 1 year, there is no amyloid deposition in the brain, especially in the cortex. This is really the area that is important, for us. So this patient became negative. Now, after this successful phase 2 clinical trial, Biogen decided to go with 2 large phase 3 clinical trials, very similar, Emerge and Engage. Each of these trials, 78 weeks, 1.5 year, randomized controlled trials, over 1,600 participants. So what happened with these 2 trials, with these clinical trials that are quite extensive and multi-center and expensive, like, for example, for aducanumab trial, for Emerge and Engage, I think each of them were like $150 million, $200 million trial. The sponsors, the companies, they try to do a futility analysis in the midterm. And if the futility analysis doesn't show positivity in the study, they stop to save money and time. That's exactly what Biogen did in December of 2018. They looked at all the data of these 2 studies by the end of December 2018. And what they found was the results were not positive. So what they decided to do, they decided to stop these 2 clinical trials, which I'm sure that Biogen wished that they would have never done so. So what happens is that it took 3 months to do the analysis. And then when they added on the 3 additional months until March of data to the previous data, they found that one of these studies is positive. In fact, Emerge became positive and Engage was negative. So let's take a look at the target engagement or target removal of these 2 studies. On top, what you see, that's Engage trial, that's the negative study button, that's the Emerge or positive study. In green, that's the amount of amyloid removal from the brain compared to placebo. As you can see, in both of these studies, the amyloid were removed from the brain. However, in the Emerge trial, the amount of amyloid removal was much, much more extensive. But of course, that's not important because clinical outcome, that's what we're looking for. Let's take a look at the clinical outcome of these 2 studies. As I said, Emerge was a positive study. It showed 22% slowing decline. What you see here in this test, this is the CDR, sum of the boxes. And this test is mainly cognitive combined with functional measures. This is the test that FDA has approved and agreed to take a look as a primary outcome. So this study showed, the Emerge showed 22% slowing down, which was clinically and statistically significant. However, Engage was negative. Now, I want you to make sure that you keep in mind this number, 22% slowing down of CDR sum of boxes, the same test. I'm going to repeat that with lecanemab and donanemab later on. Now, with this study, Biogen went before FDA and they got the conditional approval, the accelerated approval for the aducanumab on June 7, 2021, with a condition that they needed to do a phase 4 clinical trial to reproduce the results of Emerge trial. Now, Biogen started the phase 4 clinical trial. However, just last month, they decided to stop the trial because they do have, of course, share with the lecanemab. 50% of share with lecanemab is with them, and they thought that this is waste of money for them to spend on aducanumab for some good reason that I'm going to explain later on. So aducanumab will be available clinically until November 1st, and then after that, it's going to be removed from the market. Let's talk about lecanemab story. After another phase 2 clinical trial, which was quite successful, 800 participants, of showing both removing of the amyloid and also slowing down memory loss, Eisai went with this 18 months randomized double-blind controlled trial, phase 3 clinical trial, close to 1,800 participants. The treatment arm received lecanemab 10 milligram per kilogram infusions every 2 weeks, and placebo received normal saline every 2 weeks. There are some unique features for this medicine, for this study, clinical trial, the phase 3 clinical trial that I would like to share. First of all, this was one of the largest clinical trials, close to 1,800 participants in the history of Alzheimer's. Second, they included a broad age range from 50 to 90 years old. Why is it important? Because this is very similar to what we see in our memory center. So we have people as young as 50 or even younger, and then as old as 90 or even older. So this is more, I would say this is closer to the patients that we see in clinical practice. This is also one of the most diverse clinical trials, 27% of underrepresented population. However, that was mainly for Hispanics. For African Americans, still, it was about 4% or so, which was not still, quite impressive. But still, better than other studies. They also included high level of chronic medical conditions. For example, blood pressure, patients with blood pressure, diabetes, heart problems, so on and so forth. In fact, more than 30% of their participants had at least 3 chronic medical conditions, very similar to what we see in real practice. This is the first study of disease-modifying therapies ever in Alzheimer's disease that showed positivity on both primary and all secondary outcomes. This is just to show you about the target engagement. This is a participant before treatment. This is the PET scan. These are, again, axial sequences, horizontal sequences. This is after 18 months. What you see actually in the center here, that's normal. That's in the white matter. So in the white matter, we should really see the tracer. However, you don't see any amyloid plaques here in the cortex. So essentially, this patient became negative after 18 months of therapy. And I'll show you what percentage of patients became negative. This is just to show you the targeting engagement. In green, those are people on aducanumab. In black, that's on placebo. As you can see, by 3 months, there was a significant amount of reduction of the amount of amyloid plaques from the brain in the treatment arm. By 1 year, more than half of people became amyloid negative. By less than 1.5 years, almost 70% of people became amyloid negative. So quite strong medicine, but that's not enough. We're looking for clinical outcome. Here's about the same test that I just talked to you on the top, that CDR sum of boxes. Remember that for aducanumab, that was 22% slowing. Now here, for lecanemab, that's 27% slowing memory decline. For the function, that was even better, 37% slowing in functional decline. But now, when I talk about that to our patients, about 27% slowing or 37% slowing, people always ask, what do you mean by that? We don't really understand. What is it, 27%? Can you just talk to us in a probably better way? Here's just to show how it is meaningful. So just to change that, to convert that percentage to time. Here, if this is the time, as you can see, that's the trial duration, the time from 0 to 18 months, and placebo, that's a natural course. Here's the aducanumab. So people will get about 5.3 months within 18 months, slowing down of memory loss. So essentially, the gain will be 5.3 months. And the way that I explain to our patients that, for example, by 12 months, if they lose the, for example, ability of remembering appointments or dates or conversations or recent events, or for example, forgetting how to manage finances, being on lecanemab will keep that ability or skill for additional 5.3 months within 18 months period. And we think that if people are on these medications for a longer period of time, probably the effect will be stronger because they seem to be disease-modifying agents. Now, here's just to show you about the most recent data related to the lecanemab study, the Clarity AD. Here, is about the core study. And then after the core study, after this red line, by 18 months, people were put on lecanemab. So essentially in green, in the core study, what you see, that's the lecanemab group. And of course, here in the open label extension, they continued with medication. What you see here in black, that's placebo group. And as you can see, after 18 months in open label extension, they were started on lecanemab. And you can see that those lines that they were diverging, now they became parallel here. But they will they did never catch up by 24 months. Now we have actually data up to 36 months as well. Similar data that I'm showing to you here. And this is really the concept of disease modifying, meaning that people who are delayed start or they are started later on, they get better, they take advantage of slowing down, but they will never catch up with the group that they started earlier. Now, another thing that I would like to share with you in this study is that they also, because after the open label extension, there was really no placebo. So they added a placebo from the ADNI, Alzheimer's disease neuroimaging imaging. This is an observational study. And as you can see, the ADNI placebo matches very well with the placebo group at the Clarity AD. So here, after the 18 months after the open label extension, as you can see, this line diverges, right? This is probably not the best way of comparing, but that's the only way because we don't really have placebo after the 18 months within the open label extension. So as you can see, those lines diverge between the treatment versus the placebo group. So that means that most probably the effect of these medications continue up to 36 months that we have data available. So where do we stand? So lecanemab received FDA approval with accelerated approval on January 6th of last year. And what it means that FDA may approve drugs for serious conditions like Alzheimer's disease when there is a need for there's a medical need and the drug is shown to have an effect on removing amyloid plaques, meaning that most probably will have some clinical benefits. And then when the FDA reviewed all the data, it gave the full approval on July 6th. The cost of medicine is quite actually expensive, $26,500. Medicare covers the cost, but the patients need to be part of a registry. There's a CMS registry that we put our patients on. And then there's another Alzheimer's Association registry, which is called ALZNet. People are part of ALZNet. They will be covered in terms of cost for the infusions. New information, there's a subcutaneous form that may come soon. The data was shared last year at clinical trial in Alzheimer's disease in Boston. And the 6 months data shows that there is a 14% higher reduction in amyloid plaques in the brain. So it seems that even it works better. So there's a good possibility that it may come very soon. So hopefully there wouldn't be any need for infusions. Let's talk about donanemab. What's the donanemab story? Again, the same story. They had a phase 2 clinical trial successful in removing amyloid and slowing down memory loss. They went with a phase 3 randomized double-blind controlled trial, close to 1,200 participants with early stage Alzheimer's, meaning that they had either mild cognitive impairment or mild dementia. They were all proven by either CSF analysis, CSF biomarkers, or amyloid PET imaging. What they did here, this is an Eli Lilly project. They stratified by the level of tau protein in the brain. They did tau imaging. So they divided two groups of low and intermediate tau and also high tau. The results that I'm going to show is mainly for low and intermediate tau. Here's kind of to tell you what they did. they actually did a very, very interesting and novel strategy. Here in the lower section here, you see the placebo. So they received every 4 weeks an infusion of normal saline. In the top section in green, that's the treatment group. They received the dose of 700 milligram, 3 doses with up titration. And then finally, here they had the 1400 milligrams, so that was the ultimate dose. What they did, which was very, very interesting, at week 24 and 52, meaning that at 6 months and 1 year, they repeated tau imaging. Whoever became they repeated amyloid imaging. Whoever became amyloid negative, they moved them to placebo blindedly, so no one actually knew. And they continued until the end of the study. So people who became negative at 6 months and 1 year, they continued on placebo. Here's just to show you the target involvement. What you have in green, that's the treatment group. And as you can see, there's a significant amount of reduction, much stronger than lecanemab. So by 6 months, 40% of people became amyloid negative. By 48 weeks, less than a year, 70% amyloid negative. By 1.5 years, 80% of people became amyloid negative. Quite strong. It actually acted very fast and strong. Here's the same, as I said, CDR sum of boxes, the same measurement. Now remember that for aducanumab, that was 22%. For lecanemab, that was 27%. Here, 36% slowing in memory decline, kind of a little bit stronger. And for the function, 40% slowing in functional decline. Now, let's take a look at those people who at week 24 became amyloid negative and they moved to placebo. Now here, the threshold of amyloid negativity, they actually picked at 11, which is very, very low because the threshold is usually 24, but they actually came down and picked 11 to make sure that these people are negative. So they looked at all the people who are on donanemab and they became amyloid negative by week 24. And now these people are on placebo. They continued watching them. And what they found was that they didn't even become amyloid positive by the end of the trial. So the amount of amyloid reaccumulation was very slow. They did a calculation, and what they found was that it probably takes more than 14 years before plaque reaccumulates to baseline level, which is quite interesting. Now, here is just to take a look at those people who became amyloid negative either at week 24 or week 52. So the average negativity, the average week was actually 47. So what you see here, people have, after the week 47, after that red line, they were not on medicine. But you can see the divergence of these two lines. So the divergence still continues, meaning that even after stopping the medicine, when we remove the amyloid, it seems that the effect continues of slowing down memory loss. So that's quite significant and has some clinical implications. Now, here's just to show you how much time people will gain. If 0 to 18 is the natural course in placebo, people on donanemab, they got 6.3 months back. So essentially slowing down with 6.3 months back within 18 months period. These are the differences between the lecanemab trial and donanemab phase 3 clinical trial. First of all, as you can see, donanemab people were a little bit more impaired. MMSE was 22.3 versus lecanemab 25.6. The dosing frequency is every 2 weeks for lecanemab and every month for donanemab. There was no amyloid stopping criteria for lecanemab, but there was for donanemab. And the duration of therapy for donanemab is until amyloid clearance, possibly. So let's talk a little bit about side effects. The main side effect is called amyloid-related imaging abnormalities, or ARIA. There are two different types of ARIA, ARIA-E or edema, and what you see here on the top panel, A and B, that's the ARIA-E, edema. And then ARIA-H or hemorrhage, you see that down there in panel C and D. Panel D, that's something else, which is also hemorrhage, but it's called superficial siderosis. So ARIA-E and ARIA-H. ARIA-E and ARIA-H, the main risk factor is ApoE4. As you know, ApoE4 is a risk factor for developing Alzheimer's as well, but that's also a risk factor for ARIA. What I would like you to do, just take a look at the ApoE non-carriers, people who are ApoE4 negative, and take a look at lecanemab. If people are ApoE negative, ApoE4 negative, only 7 out of 100 will have the side effect of ARIA. If they have one copy of ApoE4, 11%. If they have two copies, that will be 33%. 1 out of 3 will develop this side effect. When you take a look at donanemab is in between lecanemab and aducanumab. So essentially in increasing frequency, lecanemab is the least, donanemab, and then aducanumab. Now here, just to show you how much of these risk factors contributing to development of ARIA and ARIA-E and ARIA-H. As you can see, ApoE4, that's the main risk factor, but the number of microhemorrhages, because people can have up to 4 microhemorrhages in the brain, they can be started on medication, but if they do have, the risk of developing these side effects are higher, or if they have superficial siderosis, as I said, that's another type of hemorrhage, that can increase. The other thing is that we recently noticed that is mean arterial pressure of more than 107, equal to more than 107. That's a risk factor. The amount of amyloid plaques in the brain, that has a little bit of effect as well. What are the symptoms? Symptoms are mainly headaches, confusion, visual changes, dizziness, nausea, gait difficulty, and sometimes, of course, serious reactions like seizure, stupor, focal neurological deficits, even death has happened, and of course, hemorrhagic stroke. Those are the symptoms. Now, what happens with these medications, the more time actually goes by, the less chance of developing these side effects. So it actually, at the very beginning, it's quite high. When I say quite high, it is high, and then it goes down by time. So for lecanemab, that usually happens within the first 3 to 4 months. For aducanumab, that usually happens within the first 8 months. Here's some numbers from the Clarity AD. First of all, most of the cases are asymptomatic. 3 out of 4 are asymptomatic. They have no symptoms. The reason that we figure out is just because we do the MRI surveillance imaging. Mostly that's mild to moderate, close to 90%, 91%. It usually happens within the first 3 months. And by 6 months, majority of them, 92%, happens within the 6 months. In 4 months, majority of them will resolve. And the way that we actually manage is that we hold the infusion if people are symptomatic. If people are not symptomatic, we continue. And if it's mild. If people are symptomatic or it's moderate to severe, we hold. And then we repeat MRI. When it's stabilized or resolved, we can restart medication. And symptomatic ARIA happens within 2.8% of people who are on medicine. Here, I just wanted to show you that we didn't really reach the point that we are right now overnight. It took really a couple of decades. As you can see here, solanezumab in 2007, that was the first study that showed, it was a negative study, but it showed some trend of 13% positivity of slowing down. And then in 2019, we had the aducanumab, one negative study, one positive. Overall, both of those studies showed 19% slowing down. And then finally, we had the full positivity in lecanemab that happened in 2022. and then now donanemab with 36% positivity or slowing down. So again, this has been really a process with spectacular, really, failures in the field. I just wanted to share with you the thought process why some of these studies became negative and some became positive. Here's actually looking at quite a few different studies about the amount of amyloid removal, percentage of people who became amyloid negative. That really correlates with the clinical outcome. The first two lines that you see there is about two studies from gantenerumab. That's Graduate 1 and 2. In those two studies, there was 22% of people became amyloid negative, but that was a negative study clinically. In ENGAGE trial, which was the negative study from the aducanumab, there was 27% of people became amyloid negative, still a negative study. When it came to the EMERGE trial, which was the positive study, 45% of people became amyloid negative, so there was a 22% slowing. Lecanemab, 68% became amyloid negative, 27% of slowing. And then finally, donanemab, 80% removal of amyloid, and then 36% slowing. Now, what is the future of Alzheimer's disease? It really is like combination therapy, similar to other therapeutic approaches in HIV or diabetes or hypertension or cardiovascular disease. For example, for diabetes, we start one medicine, add second, third, fourth. Of course, this will achieve when we have other medications that are FDA approved. So it would be like starting with anti-amyloid antibodies and then add on the second medicine, the third, and the fourth. In fact, we are going to start combination trials. This is a trial that is called Tau platform and will be started at the end of this year, and we will be at site. As you can see, there are 6 arms, anti-amyloid and anti-tau. 2 of those arms are combination of anti-amyloid and anti-tau medications. So this is really in the near future. Now, another exciting point is about the vaccination, active vaccines aiming at amyloid and tau. Right now, there are 2 of them, phase 2 clinical trial, which is very promising, one anti-amyloid and one anti-tau. So hopefully they will go into phase 3 clinical trial soon. So the starting age would be younger, 50 to 65, and people have intact immune system, and then there's some less potential side effects. And these medications, these 2 vaccines, active vaccines, they have a very, very good tolerability and side effect profile. What is the future of screening in cognitive disorders? And this is really not far from now, because right now we have a very strong plasma biomarker. And this plasma biomarker may get to the, actually it is in the market we use in our memory center as well, but this may become much, much more widespread in terms of using, because it's very accurate. It is as probably close, the accuracy is close to CSF biomarkers or amyloid PET imaging. So probably we're going to start screening high-risk population who have, like, for example, genetic predisposition or family history and so on and so forth, screening at the age of 45 or 50, like what we do with cardiovascular disease. Screening with the blood biomarker. People who are negative, we can probably go with primary prevention, something like statin for Alzheimer's disease. Both those BACE inhibitors, they are promising medication that sometimes probably we may be able to use them for primary prevention. So there are trials are going on with BACE inhibitors as well. If the blood biomarker shows positivity, then we may need to go with secondary prevention, for example, starting anti-amyloid and then add anti-tau therapy when they are available. So again, this is really not far from us, probably a few years from now. So are these medications, disease-modifying therapies, important? Well, to me, my goal is really to keep the best of my patients. Things that they may enjoy doing right now, they can still do perhaps months or years from now. And Alzheimer's is a chronic progressive disease, and we really want to buy time, especially now that the new advancements happening and new medications will come. And these new disease-modifying therapies seems to do that, slowing down memory and functional decline. And for some of our patients, this is quite meaningful. Not for everyone, because there's lots of burden to patients and family members, but some of them, this is quite meaningful. In fact, we have about probably 40 people either started on medicine or will start very soon. So this has been quite a, I would say, window of hope to lots of our patients. Now, impact of disease-modifying therapies in Alzheimer's disease in real world. So there are definitely quite a few different aspects. First of all, this is a multifaceted process that we've gone through. In fact, we were one of the first centers in the nation that we started the process. The medicine got the approval in July. We started, I think, our first patient at the end of August, beginning of September. But it really requires, for example, expertise, dementia specialists, familiar with Alzheimer's disease diagnostic algorithm, and also being able to use advanced imaging, for example, amyloid PET imaging, tau imaging, and then CSF biomarkers. Having knowledge of disease-modifying therapy and side effects, the ARIA specifically, and be able to manage ARIA safely and provide genetic counseling, because we do genetic testing because of the risk stratification for ARIA, but you need to also do genetic counseling because this has some really serious consequences for the family as well. And then proficient in multidisciplinary team leadership. So really the dementia practice needs to be streamlined, and also you need to have dedicated staff for efficiency and safety, but this is definitely doable. There's some access challenges in terms of healthcare system. There's first of all, inadequate dementia care infrastructure. There's a shortage of geriatricians, geriatric psychiatrists, behavioral neurologists who really deal with patients with dementia, and then dementia experienced general neurologists. Sometimes there's a difficult access to dementia diagnostic services, for example, memory clinics, particularly for underrepresented populations. If you're going to do start people on these medications, we need to diagnose very early. So essentially, time is the brain, I would say. This is actually a thing that in stroke we would say, stroke management, but that's really true now for Alzheimer's as well. Early diagnosis requires clinical neuropsychologists to do some probably more sophisticated tests. We don't really have enough. There is also a gap in neuroradiological expertise in terms of diagnosing ARIA. There's also limited access to facilities like radiology departments, nuclear medicine departments, CSF biomarkers, analysis, and so on and so forth. And also challenges of having the infusion centers in different areas. So there are definitely lots of challenges, and people try to figure out and address. So hopefully we can reduce the inequality in Alzheimer's disease.